And the webinar is live.
Thank you very much, Noreen. Hello and welcome. My name's Dr. Andrew Wilson, Chair of Cheshire CCG, and welcome to the March Governing Body meeting for Cheshire CCG. This is a meeting being held in public by way of streaming, as unfortunately, again, of course, we are still in the midst of a COVID-19 pandemic, and therefore members of the public aren't able to attend in public. As not holding a public meeting. Whilst it is a meeting in public rather than a public meeting, we do allow questions submitted by the public, which we'll come to later on. I'm not going to speak a great deal at the start of this meeting, but I do want to point out two things of I think of importance, and that both really are items of thanks. The first is thanks to Dr. Mike Clark, who is stepping down as a governing body member, having been with us since the start of this organisation, NHS Cheshire CCG, but for many years before, I think 8 years before that, with Eastern Cheshire CCG. Mike's contributions to the population and at that time, I think, have been significant, and his work and advice and abilities have been used well, and we all, I think, will join in thanking Mike for his contributions, and we are very sad to see him go, but he's going to contribute his skills, continue in general practice, but to spend more time doing research work. So we'll continue to contribute. So thank you very much, Mike. I'm sure everybody will want to join me. We do a clap, but yeah, we do a virtual clap. It's a strange thing. We do a virtual. There you go. So thanks to Mike, who leaves us at the end of this month. The other thanks I'd like to give is of course, COVID-19 will come up throughout the meeting, and everybody will know that there's a bit of a vaccination program going on, which has consumed many of our lives to some degree for a number of months now. I want to make a special thanks for the volunteers that have been supporting vaccination centres, because we had a significant number of volunteers, particularly actually in Cheshire, where we've done very well with volunteer support. I just wanted to, on behalf of the governing body, on behalf of the CCG, say thank you to the volunteers that have been supporting vaccination centres of all types. It simply would not be possible to run the vaccination programme without the support that has been given by volunteers, which has, I'm sure, in all of our experiences, been done very well, very professionally, and with amazing good humour. So thank you from us all to all those people who've been volunteering to support the vaccination programme. That will move us on then to our formal meeting. So we have apologies of absence at section 1.1. I have apologies from Ian Ashworth and Dr. Andy McKelvey, and I know that I was going to say Matt Tyra has got to leave us, but I don't think Matt's actually managed to join us by the looks of things, so we'll send apologies for Matt. And Fiona McGregor Smith has had to give her apologies as well, unfortunately, at the last minute because of a complication. So sorry, Matt has joined us. Welcome, Matt. I know that Matt does have to leave us because he has a clash for an emergency meeting at 11 o'clock. Right, thank you. So that's apologies for absence. Let's move forward to the declarations of interest. This is a pause to allow any members to point out any items in their declarations of interest, which is on our website, or any new declarations of interest, or anything which is particularly relevant to the agenda at hand today. Nobody's indicating that they. Oh, Mike, sorry.
Thanks, Andy, and thanks for your comments earlier. But when it comes to the paper 5.1, I should just make a declaration of interest that we manage one of the homes that has some discharge to assess beds, but also within our PCN, there are another 2 homes that manage some of those beds as well. Thank you.
Thank you very much. That is noted. So moving on from declarations of interest, we move to the minutes, which are on page 3 of your pack. Is there anything on page 3, on page 4, page 5, page 6, page 7, page 8, page 9, page 10, page 11. No, nothing. Our congratulations to Christine then for writing those minutes, which seem to be accurate, and we will accept as a true reflection of our discussions, which moves us on to our action log, which is on page 12 of your pack. There are two items, items 11 and item 19, both of which are ongoing. The first relates to ICP and mapping, which is going to come back to us in November, which of course has been delayed for a variety of reasons, most prominent of which is COVID-19. And the other is a scheduling of the discussion with the governing body regarding the future finance plans. My reflection on both those items is we probably need to have a think about whether they remain relevant, particularly item 11, the ICP mapping, and whether that now actually should be rolled into something different. Claire.
Yes, thank you. I'd suggest we roll that into the white paper discussions. I think that the roadmap was at a time and place, but obviously the integrated care partnerships that we currently have will need to develop into sort of the aspired to ICPs that the HCP has in mind. So I suggest we're going to be bringing back white paper discussions and updates. So we roll that in, if that's okay, Andrew, please.
Thank you. Is everybody in agreement with that? I think that does need to change as an item. It is no longer directly relevant, so it's becoming part of a wider picture. So if we can roll it in that way, I think we will need some consideration of how the governing body has assurance that in that process that the strategic objectives can continue to be met, which is something we might want to think about how that's rolled in. And then item 19, Linda, do you have a comment about that one? About how we might deal with that, whether it remains relevant?
I suppose it does remain relevant, but whether it needs to be a separate action is a different thing, because obviously as we go through the planning cycle, we receive more financial guidance, etc. They will automatically come to the governing body and go to the finance committee. So whether we actually need it on as an action, as a separate action, when it's something that will be done sort of almost business as usual, I don't know. You can take it on.
I would agree, and if members are in agreement, I think we should close both of those items. I think they should be picked up elsewhere in other ways. Is anybody in disagreement with that? No. Okay, let's do that. So we'll take both of those as closed items. Thank you very much. That then moves us on to officially 2.1, the patient story. We're going to take the patient story later as part of the COVID services update, so that will come back to you later, which moves us to section 2.2, which is public question and answers. And we do have a question from a member of the public, which I'll read out, and we will provide a formal response to this question. But I'll also invite Claire if she wants to say a word as I hand over to the accountable officers report. So the question at hand is, how can the CCG accountable officers say that they are happy with the results of the survey? This is relating to the staff survey, when Cheshire is below average in 8 out of 10 themes and only average in the remaining 2. Surely having unhappy staff is having an adverse effect on your ability to consistently deliver the service we need at a time when resources are stretched. I think that's a relevant and important question, which I'll ask Claire to address, and that takes us to section 3.1, which is the accountable officers report. So Claire, that and the question, please.
Okay, thank you. So if I start with the question, so thank you, Mr. Phillips. We will provide a formal report. So I don't think we have unhappy staff. That's the first thing I'd like to say. But we do have staff who have been through an enormous amount of change, not just in the past 12 months with lockdown, COVID, but we're a new organisation and we've been in change as 4 CCGs into 1, and the impact that has on staff for a couple of years now. So whilst not wanting to get into statistics in terms of our results being lower than average, we're talking about 0.1, 0.2%, but that's statistics and that doesn't answer the question. Of course, we would have liked to have been higher performing. Who wouldn't? And we, in the AO report, which I'll come on to now, I'll outline a number of initiatives that we are doing to respond to the staff survey. But as we'll do a formal response to you, but thank you for the question. So on to the Accountable Officer report. I'm not going to go through every single item today because a number of the items on this that I wanted to pick up are actually on substantive governing body reports. So we all know we're still in the middle of the COVID pandemic. Whilst performance in the vaccine programme is outstanding, and Tracy will talk about that in a bit, clearly patients continue to be poorly and continue to be affected by COVID. But thankfully, we can see through February that the impact on our hospitals has reduced somewhat. But we're still in level 4. We are still working with our partners to look at the whole flow and the discharge sort of processes. And Neil will be updating in today's report about the plans we've got for increased investment to carry through the work we've been doing. To assure you that the work of the COVID group still is reported through to executive team, and you can see the decisions at the back of the paper. But to record my thanks too, as Andrew has, to the volunteers and also to the CCG staff and all our partners, so GPs, hospitals, community mental health, third sector, and I'm not going to keep going, so I'll probably forget somebody, but really it's just an enormous partnership effort, and it's been outstanding, so thank you. I want to just pick up item 4 in terms of the mental health support teams. This is great news that we've been successful in the bids for Wave 3 and Wave 4, building on Wave 2 in Ellesmere Port. Clearly, mental health for our children is an absolute priority. And I think this is really positive, this initiative, in terms of building together health and education. So I think this bodes well for the future, but we need to bring back, and we have made that commitment, we'll be bringing back some more information and papers around mental health spend and mental health priorities at a future governing body meeting. But I think this is really positive news in terms of our population of young people. We want to build on the successes in waves 2, 3 and 4 and put a further bid into the national team for 5 and 6. So I guess a follow on from the question from Mr. Phillips. So we have taken part in 2020 in the NHS staff survey. This isn't compulsory for CCGs, but we made the decision we wanted to hear the views of our staff, and I'm really pleased that we had a really positive response in terms of, I think we're above average, over 80% of our staff completed the survey, and I think that demonstrates a willingness to engage and be heard. We've been very clear that obviously all the responses were confidential and anonymous, but I think it's really positive that our staff wanted to contribute. So whilst we're not above average on lots, we are about average, and I think that puts us in a really good position in terms of moving forward. We now have a baseline sort of position that we want to build on, and we're really keen to move this forward. So obviously we now have Christine as our wellbeing guardian, and I've met with her, with Andrew and with Matthew and with our organisational development provider, Health Skills, to look at how we can move this forward. And this isn't just a governing body move forward, this is absolutely engaging with and listening to our staff. So you can see in 5.8 we'll be moving forward with our HR ops and staff engagement group. We'll be going back to the behaviour charter. We'll refocus on the values that we're all assigned to, and looking to develop a further CCG equality, diversity and inclusion group. So I think there's some positive developments ahead, but thank you to all the staff who took part in the survey. You'll see on item 6, the exec team receives monthly reports around our workforce metrics. So in terms of greater transparency, I'll be sharing these on a monthly basis with the governing body, so you can see where we're up to. We've made some positive progress around equality and inclusion, where we have been viewed as achieving. I'm not sure the language is particularly positive, but achieving, if you look at 7.5, is actually the CCG is doing well on this agenda. And obviously EDS is among the processes mandated by the NHS to demonstrate our commitment to eliminating unlawful discrimination and promoting equality of opportunity for all. We focused on the two bottom of the goals on 7.2 for the survey this year. Good work's taken place, and we've got plans to build on that. Item 9, clearly the white paper is sort of, apart from COVID, is consuming our thoughts and our work plans at the moment. So early discussions with the Healthcare Partnership, Cheshire and Mersey, around commissioning functions, because as we know, if the white paper goes through Parliament, the CCG, all CCGs nationally will be abolished. And so we're now beginning to plan for the future. So we'll be doing that with our partners locally in Cheshire East and in Cheshire West, and with the Healthcare Partnership. So I think there's lots of work to do, and what we are proposing is that the governing body development session on the 25th of March, along with conflicts of interest, we will have an opportunity to look at the white paper in detail, what it means for the CCG and how the governing body and the CCG move forward over the next 12 months. So that's a good opportunity. So I will remind you all, please, if you haven't done so already, please read the white paper, and we'll send some further information out before that event, just to remind you where all the links are. You can see under item 10, there's a long list of decisions taken under executive authority. So these will be the decisions taken by the exec team at the exec team meetings and at the COVID-19 exec meetings. So happy to take questions on any of that and anything else in the report. Thank you.
Thank you very much, Claire. I now have Christine has got some questions for you.
Thank you. Just a comment, really good to see the workforce data in the report for the first time. I think we need to continue to prioritise the workforce metrics, and I know there's going to be some further work ongoing with those metrics to make them a bit more real and meaningful. But really good to see that in there, and really good to hear that learning from the staff survey and all the other sources of staff workforce feedback is going to be moving forward. I think relating to the question that was made earlier, we do need to aim high with our workforce. They are our most precious possession and vital to the NHS. So just a comment, really, that's good to see that there.
Thanks, Christine, and thank you for your support so far. I think that will be really important, and I know you are going around each of the directorates, and I know you've been to quality and patient experience and safeguarding this week to meet the staff and be visible, so that's fantastic. Thank you.
Thank you very much. Leslie, I think you've got some comments.
Yeah, so just a couple of questions. Mine's about the workforce metrics as well. I think I've not seen this before, so I think it's really good to see. Just a comment about, we seem to have, I suppose we talk about this sort of equality inclusion and that we're achieving, but we have very low percentage of Black and minority ethnic staff members. So I just wondered how we were encouraging people to join the organisation from those groups and how we support them. The other thing I noted was that this may be something that is part of other organisations, that there seems to be a significant proportion of sickness due to stress, anxiety and depression, and how we are supporting staff with regards to that area, whether we have support mechanisms in place. So those were just my questions.
Okay, thank you. So yes, I agree in terms of the ratio and percentage of staff. We do all we can to promote the organisation. I think the NHS is an equal opportunities organisation, and we definitely are. So we continue to promote. I think there's some legacy issues, probably, Leslie, if I'm honest. And I think as a sort of Cheshire, as a sort of demographics, I think sort of the BAME community are not particularly well represented in the population. So I don't know how disproportionate the workforce are to the population. But we do everything we can, and we will do more. I think in terms of the NHS plan, that gives us a lot of good markers and indicators around this. So I think in terms of the proposed inclusion group, We're working through the NHS plan at the moment, and I think we're looking at bringing a health inequalities update at either April or May's meeting, so we can bring some further information about that, if that's helpful. In terms of staff sickness, clearly there's the ongoing relationship with line managers. We have occupational health, we have we have mental health first aiders, and we have our counselling services. We do as much as we can, but clearly that we'll always be able to do more. And I think it's about listening to the staff, understanding, you know, what the issues are, doing that anonymously, doing that in a compassionate way, thinking about our values and the behaviours. But I think, you know, I'm pleased that you're, you know, that we're now sharing this information, because I think it holds us all to account. And I think that's something that we'll work on in the coming months. So thank you.
Thank you. Matthew, do you want to come in on that?
Yeah, thank you, Andrew. So in response to a couple of the questions, so it was a discussion we had late last year in terms of what we wish to aim for as an organisation, or as a governing body, around any kind of targets, and it was an ask of the people plan. So we do need to revisit that at some point, but agree with everything that Claire said in terms of how we try and attract different groups of people who would not normally see either the NHS or working in a clinical commissioning group as a career goal. And that's going to be one of the roles of the sort of equality and inclusion group, to see about our recruitment practice as well. But we are inclusive, because we do take advice from our commissioner support unit in terms of making sure all our adverts are correct. But there is work to do. We're middle of the pack in terms of comparative CCGs, but it is also reflected on the communities we can draw from. And just to add, in terms of the support, in terms around stress, anxiety and depression, one of the things I know Christine might want to talk about, but on the people plan, there was this thing called now an introduction of wellbeing conversations with each member of staff, and that is something we're working on in terms of like the national rollout of this wellbeing conversation, and that will help with those managing hopefully some of the issues people might get to around stress, anxiety, depression as well. So we can bring further updates, because, you know, we did commit to give a further update on progress around the people plan. So again, I think scheduled in the next couple of months.
Thank you.
Thank you very much. If there's no further comment on the AO's report, it seems to be anybody else wanting to speak, and we are simply asked to note the contents of the reports and record our assurance and the approaches being taken. So I believe we can do that. Thank you. That takes us to item 5.1, which is the sorry, doesn't it? It takes us to item 4.1, which is an item around vaccination confidence. So, and Tracy is taking this item for us. Tracy.
Thank you, and good morning, everyone. So I'm going to lead off, but I know I've got Matt Tyra possibly going to give me a little bit of help with some of the work that's going on from a Cheshire East point of view, and Ian Ashworth, who appears to be masquerading as Claire Watson, but he's also going to give us a little bit of help as well with his Claire Watson label. So thank you very much. We wanted to bring something this time to focus particularly on how we are amending, adjusting, adapting, and making sure that one size doesn't fit all in terms of the COVID vaccination programme. So in previous governing body sessions, we did a very in-depth question and answer session around how we're delivering the vaccine programme. So I wasn't going to go into great detail. I suppose I'll just cover that off very, very quickly, and then we'll move into the detail within the paper. That we continue to see a tremendous effort, and I back up your thanks to a range of stakeholders across the Cheshire population, really. So I think we do need to say a huge thank you to all our staff who have contributed to the vaccination programme across multiple partners and multiple organisations. I think that, as you say, the volunteers who have been involved have been absolutely outstanding, the partnership working, and also our patients and our population. And I suppose this particular item reaches out to our population to say thank you for having confidence in us, and this is to try to build that confidence even further as we move through the vaccination programme. We are on track to continue to deliver our targets to make sure that by the 15th of April, anyone in priority groups 1 to 9 has been offered and ideally received their vaccine and taken up with confidence that offer. We are on track, but it is a challenging piece of work, and many people are doing that on top of their existing work, and I think that that's a massive challenge, and I think we should be incredibly proud of how that's been delivered. We've been advised that there are some groups who need additional support and would not necessarily be serviced by a standard offer in terms of the vaccination programme. And there were a number of questions about this in previous sessions, so we wanted to bring something that focused on that particularly. And so the report that starts on page 24 of your pack has, as you'll see, been put together with support of many. And this really, I think the message I'd like to get out is about how we continue to build confidence in all sections of our population, but not necessarily from a health point of view. This is about the connections that we have with trusted relationships, not just around the COVID vaccine, but how we make sure that people are engaged with services that could support them beyond just having their vaccination. So, key things to note from that is that I hope this will provide the governing body with assurance as to the approach that we're taking, but it isn't one approach, it's a multifaceted approach, and one size doesn't fit all. So in each of our primary care networks, of which there are 18 across Cheshire, it is about adapting and flexing to meet the local population needs and working within that care community so that we're using different third sector and charitable resources, trusted relationships that are already there, but also the input that we've got from our primary care networks with trusted colleagues in terms of health services. So I don't think it is just one size fits all. And I've said that several times now. Things that we've done. First of all, we've continued to have a range of local sites so that people can, if they wish to, have choice as to where they are vaccinated. We continue to have 5 pharmacies across Cheshire. We have 18 primary care networks and 2 larger vaccination centres. We had 4 hospital hub sites, and they are flexing in all of these sites, flexing capacity to meet demand. So that's a wide provision, which means that people are not necessarily only being given the offer of a mass vaccination site. People can also travel out of the area if they wish to the Manchester site, Birmingham, or if they would like to go to St Helens, but it's about giving choice. With each of our local authorities, I'm very pleased to say, has worked incredibly closely with us to make sure that they have reviewed the transport available to those sites and made sure that there is an offer available, that would not be a barrier if anybody was struggling to get to a site. Each of our PCNs has then worked for how they vaccinate those people who are housebound, and even if transport was available, they are not excluded from this programme. Other key things to note are that we've been supported by Fire and Rescue, who have started to undertake safe and well visits for those who have not engaged with us, and so rather than just accepting that, have gone out and made sure that we've done checks on not just whether or not they wish to have a COVID vaccination, but other aspects of safe and well. So this is about a very holistic approach. So there's an awful lot within that paper, and I think it's just about understanding that we've drawn on a range of different support. Health Watch has also helped us, particularly with our boating community, which is something quite unique to Cheshire. And the other things that you'll see in there is that there's a very strong push for us to make sure that everybody is registered with a GP. That's the biggest way that we can make sure that someone is not forgotten, not just for the COVID vaccination, but also for flu jabs, for other checks that may come up, and making sure that people are then able to access other health services and care services as well. So So I'm going to ask Ian and Matt to come in a minute, if that's okay. We've also received really good assurance on the work that's taking place to engage and ensure that our care home staff and care home patients receive high take-up of the vaccination, and that we continue to work with those different parts of the population. So I think that we commend both our local authorities for the work that they've done on that, and I'd like to thank them personally for that. So I think that probably concludes what would be useful to go through here. Just last thing to note is also that there's been a massive continued effort from the comms and engagement staff who work on this. This is about engaging with our population to ask them what could be preventing them to have confidence in the vaccine, and then addressing that. So this week you'll have seen a couple of webinars that have run to answer some of those clinical questions that people may have had, and that work continues, where as things change and as we move forward, that we continue to respond to what things people are asking for more information on. And I will always refer you to the CCG website, where we have some frequently asked questions, and each of our partner organisations also link back to that website. So we've got one set of questions that are signed off by our clinical leads, so that they come with the confidence of a clinical view, and that then provides that single point of contact that should provide the confidence. So there's an awful lot of different strands in there. Ian, Matt, would you like to add to what I've said as to the work that's gone on to ensure vaccine confidence?
Should Matt go first, since he has to leave at 11?
Yeah, no problem. I was just fumbling with my mute buttons. Apologies. So I think there's been a phenomenal amount of work being carried out by a huge range of organisations, both and with a range of underserved groups. But I think all of the organisations that have been involved need to be commended. Speaking on behalf of Cheshire East Council, we've been working with many different parts of the council in order to try and deliver this, as well as getting outreach into our communities. So there's been fantastic asset-based, community-based work being carried out by our communities teams within the local authority, with a view to ensuring that we identify community champions within specific communities of the population, make sure that materials are presented in suitably translated ways, and we're doing that alongside the communications team, particularly where we are getting that behavioural insight type work and identifying some of the barriers that we can help to break down in terms of what might stop people from attending for a vaccination. We've also done strong work with the homeless within Cheshire East, again building. A lot of this has built on some of the methodologies and networks that we've either made use of or that have been created in order to improve the testing rates. So one thing has led to another. It's enabled us to do a degree of that kind of harmonious spiral type approach, where you build on the successes and trust that you've already built, particularly on a topic area where there is a huge amount of misinformation, reasonable and appropriate measured concern that needs to be supported to break through, but also a lot of disingenuous information that is factually incorrect out there, and that we're working on, not only as teams within local authorities or within CCGs or all of the other organisations that have been part of this, but as networks across both the sub-region, region and nationally, in order to try and tackle some of the challenges that are coming out, particularly in terms of misinformation.
Thank you. Ian, are you going to add?
I'll just to say it's excellent partnership work locally with us all, really. So great, very similar approaches with that Matt's described there with our community champions. So I suppose to give the board assurance, really, that me and Matt are both on the governing body, but all our teams are working exceptionally closely together. There's emergency planning meetings around the vaccine control, both gold, silver type arrangements in place. And some of the things that we've really done on the boots on the deck really is thinking about where some of our minority communities are and how we best do that with the right voices and right leadership. So this week jointly with the CCG and the Clinical Commission Group, the Integrated Care Partnership, myself, we had a couple of local GPs, Dr. Jivan in Fountains and Dr. Emily from Ellesmere Port, and then Joe, who's one of our pharmacists from Whitby, did a fantastic webinar aimed at facts and figures, encouraging confidence, ask anything you want, what are your issues, and it went down really well attended by lots of our communities and ethnic minority groups as well. That's going to be seeing plays out a lot more. I think we should be doing more of them. About that local response really as well, so where sometimes in more of our deprived areas uptake we really want to see high. It's been fantastic, but we have to jump at every opportunity to maximise it. So Dr. Bianco was already quickly to put something out on from One Ellesmere Port Primary Care Network yesterday to reassure local residents, and that's really important. We've had the local imam, the chair of the Blake Mosque, and also chair of the Chinese and Indian associations putting out core messages around vaccination and testing. Again, that's really important because the key gatekeepers and leaders and trusted people in their communities. The community champions that Matt's alluded to, we've got about 400 in Cheshire West. I'm sure it's similar in Cheshire East. That keeps growing, and again, help get that, dispel any misinformation out there, and we can respond very quickly. We've also been doing some work with some of our third sector agencies like Chorek, who are going to be doing a door-to-door knocking information session as well. At over local level, the Learning Disability Partnership Board that we have, the CCG are actively involved in. We really need to do more and make sure that our residents with LD, learning disabilities, are registered with their GPs. Many benefits of not just getting the vaccination for doing that. So that you see a lot of communications about and pushing for us to be doing that. Couple of specific things that the CCG and our teams collectively are going to be working on. We've asked for is really deep dives now into some of the data. Not just ward level, but in neighbourhood level, where we know where some communities are really closely linked and what those issues might be, are whether that be accessibility, the challenges of uptake. I know it's obviously well documented some of the national supply issues, but we really need to understand some of all of that and act upon that. So that's one of the things that the Clinical Commission Group's business intelligence functions are working with us on, and I hope to see a lot more of really. And I think hopefully that, I mean, we could go on our traveller teams as well, doing lots of outreach as well, and dispelling myths and getting people linked into our Helsby practices, for example, as well. So, yeah, there's loads for us to be doing. I think what the work that Tracy's explained is fantastic start, and it just really shows what the merits are of us all working together locally on localised issues for our residents and communities. So, thank you.
If I may just add, the other element that I would say around this is that these are challenges that we face with a whole range of different things. And I think the proactivity around these approaches has built quite a lot of trust with groups where we have been successful, and the opportunities for broader health implications as a result of those contacts and the networks that have arisen as a result of this gives us potentially a strong footing for the future in terms of improving access to services and the health outcomes for people within the underserved populations that we've been targeting. The other element that I forgot to mention was the strong work that's gone on in Cheshire East around accessing hidden and unpaid carers, with significant work being done through the Carers Hub for people who might otherwise have not come forward for vaccination under the Carers Priority Group.
Lovely. Thank you very much. Tracy, do you want to add anything more? Otherwise, I do have some people asking questions.
No, I think it's just to note the multitude of work that's gone on, and that I hope that gives governing body assurance it's not done. It continues and will continue to adapt and flex. And I think you're absolutely right, Matt. We have seen some very positive spin-offs for this. More people are registered with their GP. More people are now registered as a carer or marked as a carer. We can therefore support people more with their general well-being much further than beyond a COVID vaccination. So I think there are some ongoing health benefits from this, and so this work continues.
Thank you. So Claire, and then I have Pam with some questions.
So thank you. A lot of what I wasn't going to say at all, but it was sort of the same theme. So firstly, a big thank you to Matt and Ian for their sort of place leadership, but also for the inputs across the sub-region and beyond, really. I think it's you know, been an incredible journey that everyone's had and a partnership approach, but particular thanks to you two and your teams. So thank you. I really welcomed this paper because I think, you know, we always receive, don't we, sort of the headlines, and because unfortunately as an NHS we're not allowed to share the detailed numbers, so we sort of get the positives around meeting, you know, national deadlines, but this actually I think takes it down to the local level and the work we should be doing in terms of really targeting you know, the sort of the local population. And I think, well, it's great work, so thank you. But I think we should be doing more of this. I think we need to get into the detail in some of the future discussions that we have around COVID, but also I think, you know, sort of the legacy and how we move on from this, particularly all the fantastic work around the insights work and around the local populations. And it's really, I'm really pleased to know that we are going down to sort of road level, because then that really targets all the people rather than having just the headlines. So thank you.
Thank you very much. Pam?
Yeah, I think it's a great report. Some really good information there. What I would ask is, and I know we can't have figures, but I'm assuming this has made a difference. It doesn't say that in the report, but I just make an assumption that it has. Has it?
Would you like me to comment? I know Ian's trying to comment, so I don't know if Ian wanted to come in first.
No, after you, Tracy. That's fine if you want.
I think it's very difficult to attribute cause and effect, Pam. So I can't give you guarantee that we've done A and it's resulted in someone having a COVID vaccine. Anecdotally, we've heard that people feel more assured by each of the different things that we've done, and we know that people are saying, oh, well, let's have more of it. So certainly the webinars and things like that, people are finding it very useful. Has it made a difference? We do know that we are getting good uptake from all groups across our system. There are some areas and some geographies where we know we've got more work to do, and that's where we continue to work through that. And that's an ongoing process where we are working with our integrated care partnerships and our PCNs who have said that they know their local population better than anyone, and I think that's fair, and asking them what more do they need from us and what more can they do to make sure that we get that take up. So I would say yes. I mean, we put a lot of effort into something if it hasn't made a difference, and certainly the feedback that we're getting is that it is helping. So I think we should continue.
Thank you.
Ian, do you want to jump in?
If you wouldn't mind, thank you for raising it, Pam. So on a more and I'm just speaking Cheshire West here, but I think with it's quite a similar picture in Cheshire East, but the infection rates you're very much seeing. We know our infection rates are the most highest in the 30 to 39 year age group. The group in predominantly haven't been getting vaccinated unless they've got obviously, you know, clinical vulnerabilities they're invited to do. They're going out more to work still, and can't always work from home in some of our sectors as well. So that's probably, you know, a mixed thing. Whereas actually, you know, the priority 1 to 4 groups or the older age groups, we have seen a you know, substantial decline. Now there's a few factors in that. Obviously the vaccine has to be making a major impact. It would reduce demands on our hospital settings for more severe implications, and the deaths that have obviously petered out as well, reduced significantly, should I say. I mean, obviously that's in line with the stay-at-home messages and the social distance and everything, the lockdown levels that we've done. But, you know, quite rightly, it is having an impact. So with our colleagues with Public Health England, we were actually looking at some of those comparisons of care homes last week, you know, ones were vaccinated and were not, and it really promising some of the information coming out that shows like where those care homes have been vaccinated and staff at higher levels, that it's less impact and mortality and hospitalisation going on than compared to those other ones. So we're starting to see some of that. I think there was another national publication on the impact of the vaccine on transmission that came out. It might have came out midweek this week that we need to get to and look at. But it is clearly making a difference. Regarding the uptake rates in some of our ethnic communities, and some of our more deprived communities. That's something we need to really get really close to and understand now that we're starting to go through the different priority groups and age ranges and the different challenges that exist there. I think we should be exceptionally proud and thankful to our over 65s to leading the way, and that uptake is marvelous. They really have shown the rest of us that's what you do. Like, so, but there's going to be different challenges with that. Where we've already been picking up, there's been questions and concerns, misinformation around the fertility elements of things like that. So they're what we've been addressing. So it's making difference. The other thing I've just forgot to mention, and I will get into trouble if I don't do it, is Health Watch and the work that they've been doing as well. You know, and get that engagement with our residents as well, and that really informs how we respond locally as well. So we will continue to obviously closely monitor it and have the plans that Tracy has put into place.
I think, Tracy, you want to come back, then we're going to go to Leslie. Tracy.
Very quick comment. It may just answer Pam's question more thoroughly. I think, yes, absolutely want to record the thanks to Health Watch. We can see as a result of some of the work that they've been doing and all of the other aspects that GP registrations are up in particularly marginalised groups. So I think that does give us an objective measure that we are seeing some positive impacts that will have long-term benefits. So I think there's a clear yes to your question and as an answer.
Lovely. Thank you very much. Leslie.
So yeah, thanks for all the work that's ongoing. I think there's been phenomenal effort, really. My question is that I suppose around the kind of priority groups, and that sometimes these difficult and hard to reach groups are not going to come in a sort of cohort group. I suppose as an example is the travelling communities are quite difficult to get to, and I suppose what you don't want to see is that somebody manages to get in and has that trust and has those communications open and is able to vaccinate, to go in and then be restricted in who they vaccinate at that time. So I think there needs to be some flexibility about being able to go in and actually vaccinate, not just go in and vaccinate grandma and then try and come back and then vaccinate sons and daughters. And I think it needs to be a whole effort, and there should be, I didn't know whether there was any flexibility in that, because it makes very sort of common sense to me, but whether we are restricted in that sense, because that would make life easier trying to access these really difficult groups.
Okay, if anybody has any thoughts on that?
I'm happy to respond if that would be helpful.
Tracy?
I would totally agree with you. We're encouraging people to get the vaccine when it's their turn, but you know, at the moment the priority groupings are, as you know quite clearly, anybody over the age of 50. So if you did have someone that's in one of those marginalised groups that doesn't have a clinically extremely vulnerable reason or is the wrong age group, you're kind of saying, well, thank you very much, but not today. That's very difficult. What I would say is that we are not able to deviate from the national guidelines. We're all being asked to apply those equitably. So I guess that's where this comes from. It's not a clinical commissioning group decision as to veering away from those groups. So I think in time that will open up, and as you know, it'll be for all over the age of 18. I think the only thing I would say is that, and we are operating that no waste vaccine, so there is pragmatism around that, isn't there, around not wasting any vaccine when you've got that engagement as well. But ultimately we do have to stick to the national guidelines, which are very clear about that I do think makes it very difficult on the ground.
Okay, thank you. I'm not sure that was the answer Leslie wanted, but that's the answer that as it stands, I think. Lovely. Are there any other questions regarding the?
Okay, could I come in and just,
yeah,
I mean, obviously there has been some changes in the guidance as around like homelessness, and I know thinking about the cohorts are really difficult to get to, and there is obviously the JCVI guidance, which I think we've been exceptional in managing and supporting and understanding, but given some real challenges when you think about other frontline services and like the police and teachers, etc. I do think Dr. Appleton's concerns around that is really important, and if it is you know, the clinical decision to be rolling that out and getting that uptake about that, I think that's a really good thing for to be doing it, rather than putting other barriers in place for that group, which might have actually other unknown health issues and things like that. So I think there has to be some sort of flexibility wherever possible to deliver that more localized arm, no pun intended.
So yes, well done. Get the arm in there. Perhaps the approach we need to take here is we have been in this sort of situation before with this vaccination program, haven't we? There are very clear guidance coming down to the top, and they've been chosen for very good reasons. But there are also on the ground operational reasons to do things slightly differently, and there are sometimes ways to marry those two things up in a way which is acceptable and pragmatic. But it does involve going back and feeding it back up into the system, doesn't it, and seeking what's appropriate and what flexibility there is. So I think we've got a clear demonstration of a need there, and as he's brought to us, and perhaps that can have some thought around that and see how we might be able to operate without going outside of what is accepted on the priority groupings. Okay, are there any other questions on building vaccination confidence in Cheshire? No. So thank you very much, everybody, for that, and thank you for bringing it to the governing body, and thank you very much for the work. It is clearly extremely important, and I think you can tell from the debate how much appreciated it is that the governing body's had the opportunity to debate that. So thank you. I will just add thanks from the governing body to everybody that has been involved in the programme as a whole, but in particular that finding those groupings that are more marginalised. So let's move on to our next item, which is item 5.1 on page 41. Oh, sorry, we asked to note that paper, which I assume we've managed to do. On to item 5.1, which is COVID Commission Services Review. It's on page 31 of your pack. And actually, just before we go into that, so I'm going to hand over to Neil any second. I just want to correct the record for Ian, because we gave apologies for Ian at the start. Clearly, Ian is with us. He's not only is he with us, he's now labelled as Ian Ashworth, which is even better. Yeah. So my apologies, Ian. You were down as apologies, and you hadn't joined the meeting, I think, because we hadn't given you a link, so you couldn't get on. So welcome, and apologies, we'll correct that. So COVID Commission Services Review, Neil.
Thank you, Andrew. So there's two parts to this paper. When we discussed, I think at the last governing body meeting, we said it would be helpful to provide an update on some of the decisions that are being taken around the services that we've commissioned during the past 12 months in relation to the pandemic response. But then we were also very aware that many of those services have been commissioned on the basis of 31st of March being the end of the financial year. And I guess at the point of commissioning, due to the uncertainty around the path of the pandemic, a belief that we may not need some of these services going into the new financial year. So the two parts of the paper give a general update on a range of services, and I'll touch on a couple of them, but I don't propose to go into lots of detail, but we can answer questions on those at the end. The second and more material part of the discussion is around Appendix A, which is related to bed-based rehab and reablement services in Q1, which has a request for the governing body to agree expenditure up to £1.04 million. So the additional context that you will pick up in item 5.3 later when Linda talks about the current financial position is that as it stands today on the 18th of March, we are still awaiting national financial planning and operational planning guidance for Q1 and the remainder of next year. So we are currently having to develop plans in the absence of that clear national guidance around what our budget is, what our allocation is, which is clearly a slightly unusual position to be in at this stage of the year. So just in terms of the general updates, the one area I was just going to highlight to you, and it's probably useful to reference this back against the table, which is in section 2.1, is we had a number of services which were either commissioned to run for 12 months, which overlap the 1st of April, start of the new financial year, or which ended on the 31st of March. And hopefully the brief summary within the paper has helped give you a feel for what those services are and whether there is a financial impact as well as a service impact going into the new year. Now, some of them have no financial consequence because we actually funded them up front and they'll just run on to their natural conclusion. Some of them we will need to make decisions going into the new year. An example of that would be the minor eye care service, which was commissioned to run for 12 months and is roughly halfway through that period. So we will have to make a conscious decision during the early part of next year as to what our longer term plan is, but we're not quite at that point yet. However, there are some where there is a significant financial implication at the start of the year. So that the one I was just going to highlight that I think there probably is a bit more context on, the commissioning of hot hubs, virtual wards and pulse oximetry services, which I think it's probably useful to highlight because we've had lots of debate about the ongoing need for these services on the basis that we all watch the news each night and can see the graphs in the 5 o'clock briefings showing that COVID infection rates are coming down at a very, very reasonable rate and everything seems to be getting better. However, we're still proposing to spend a reasonably significant sum maintaining those services into Q1, and there's some good reasons for that. We still do have significant rates of infection, even though they may be coming down. That as we head into April, we still have a need to assess people who have potential COVID, and that is in line with the National Standard Operating Protocol for how you manage people with suspected COVID, which hasn't yet changed. So we do need that service. The other thing that we did, because we were conscious of the risk of having services sat there with expensive and valued clinical resource in them and very limited activity. So our partners across the ICPs have integrated these 2 new national initiatives, virtual ward and pulse oximetry, into those what we call hot hubs, so that the staff, the administrative and clinical staff, are fully utilised. And what we are proposing in Q1, in line with many of our plans, is to downsize them in terms of the size and volume of staff working in them, but to maintain a presence to make sure that patients have access to those services. So as I say, I wasn't proposing to go through the remainder of those for noting schemes at this point, but happy to pick up questions after. I was going to spend most of the discussion talking about the ask for agreement in relation to the bed-based rehab and reablement services. But prior to doing that, and as Andy neatly trailed at the start of the governing body meeting, colleagues from across Cheshire have produced a short 4-minute video which describes something called Home First, and we a very useful introduction to what Home First is and how this investment not only helps with our continued response to the pandemic, but also our longer term aspiration around supporting people into their own home wherever possible after a stay in hospital. So hopefully Noreen's at the ready and has a link to a YouTube video, which, as I say, colleagues from across the health and care system in Cheshire have produced for us to have a look at.
Hi, I'm Dr. Rebecca Banks, GP and Urgent Care Lead for Cheshire CCG. Over the next few minutes, we'd like to describe to you how we're going to be working differently across health and social care to ensure our patients get the right care in the right place, and how we support patients and their families both during and following an acute illness or injury. We'd like to describe the steps we are going to take to ensure we respond rapidly to people's health and care needs, offering choices and an appropriate level of treatment and support. Our ambition is to aim for a timely hospital discharge when people are stable. and we would like to show you how this will be undertaken in a way in which patients and their families are safe and well supported. I'm sure you'll agree this last year has been very difficult for all of us, and our health and care services have had to adopt new and innovative ways of working. However, out of this challenge have come new and exciting approaches to meeting patient needs, and this has been well received by both patients using the service and people working within it. Which initiative is called Home First, and this is what we'd like to share with you now.
Doris was admitted to hospital with worsening confusion in May 2020. Prior to admission, she'd been living with her daughter-in-law and had no package of care, although was nursed in bed and had significant care needs. Doris had a background of cognitive impairment due to vascular dementia and had been deemed to lack capacity in relation to discharge plans. Initially, Doris's daughter-in-law was reluctant for Doris to be discharged, with carers coming into the house, expressing her concern was related to the risk of the carers being infected with COVID-19. However, following discussions, she did agree to a 4 times a day, double-handled package of care with the rapid response team.
My name's Katrina Oliver. I'm the manager of the Integrated Discharge Team here at Macclesfield District General Hospital. This year has been a particularly challenging year for everybody, but especially for our patients in hospital, as during their stay they haven't been able to receive visitors, and especially in their hour of need when they're at their most vulnerable. Adopting the discharge to assess approach early last year reinforced the Home First approach and has had a positive impact on our patients. The discharge to assess pathway model is based on 4 clear pathways on discharge. Pathway 0 relates to simple discharges requiring no formal input from either health or social care. Pathway 1 is to support people at home whilst they recover, enabling them to return home with either a package of care or reablement. Pathway 2 is for people requiring a period of rehabilitation following their stay in hospital and is usually in a bedded setting. And Pathway 3 is for people requiring ongoing support, often in a nursing home, and are likely to need this long term. Having adopted this approach and working closely with health and social care colleagues has enabled us to care for our patients in the right place at the right time, with the emphasis on supporting people on discharge to maximise their independence, build up their confidence and hopefully get them straight back home.
The Home First model provides a number of positive outcomes and benefits for service users, focusing on integrated, timely, personalised care which maximises independence, ensuring the service user is receiving the right care at the right time in the right place.
The Discharge Hub, set up in November 2020, was my project. We had health and social care staff. We came together, we set up all the processes from scratch, and it works.
So thank you. That's what happens when you go on holiday for a week. I went on holiday and arrived back on the Monday to be presented with a video that the Cheshire Flow team had developed. And the Cheshire Flow team is one of the ways of working that's come out of the pandemic, where colleagues from health and care across Cheshire, all the providers and other linked partners get together on a weekly basis and are working in a very collaborative manner to develop services, design services, learn from each other, and that group of people are all linked into that. And as I say, I didn't know about it until Monday, when they presented me with a video which they felt helped them describe the story as to why they're also committed to Home First. So I'm going to focus a bit on Appendix A, because clearly the ask of significant investment going into Q1 in the absence of a financial plan is not a usual situation to be in. And just to build on that background around the Cheshire Flow Group, that's a subgroup of the Cheshire A&E Delivery Board. And over recent months, we've been collectively working to continue the pandemic planning in relation to what it is we need going into the new year. And part of that is complicated further by the fact that during the pandemic, As you'll be well aware from some of the extraordinary governing body decisions we've taken over the past 6 months, we've had access to something called the hospital discharge policy funding, which has allowed us nationally to use national funding to support the investment in a range of community services, which has supported the ability to discharge people from hospital or avoid admission to hospital through increased capacity in the community. So does the need continue, I guess, has been the key factor we've been working on, and the assessment and modelling we've done has identified an ongoing need. And I'd just like to talk through one case study which I think helps demonstrate this. And myself and Linda met some colleagues from East Cheshire Trust yesterday to talk about exactly what their plans and rationale were for going into the new year, and it really helped resonate as to why we need this capacity. So if I just take Macclesfield District General Hospital, and I could apply this to any of our hospitals across Cheshire, when the pandemic started, their first immediate need was to create ward areas which allowed them to follow infection prevention control procedures and maintain social distancing between people who either have a positive diagnosis of COVID, suspected COVID, or no symptoms or suspicion of COVID. And that need hasn't gone away. And what that means is at Macclesfield District General Hospital, they effectively closed their on-site intermediate care ward to make a COVID ward. And that is why we then commissioned a range of beds in the community to ensure that we had sufficient capacity. So when we talk about investment, the net position, if you were to compare year on year, isn't that we have more intermediate or community beds. It's just that we've had to commission more in the community to free up capacity in the wider system. Now, has it worked, I guess? And, you know, if we go back to some of the decisions we've had to take over the past 6 months, there's been a lot of questions around, you know, does this model work? Will it be effective? And the data and the analysis and the anecdotal feedback from the teams on the ground is this really is working. So if we take units like the largest one we have, Weston Park, which is the one that was brought in Macclesfield to replace the on-site ward, we are seeing better outcomes for patients, reduced length of stay in intermediate care, improved ratios of people able to go home at the end of their stay, because we've been able to provide a much better experience for them in a non-acute setting. Because even when we have intermediate care on hospital wards, it's very difficult to lose the ethos of a hospital-based intermediate care ward versus a more community focused one in a care home. So the evidence is suggesting it's working. The challenge, as you'll imagine, is always comes down to how does this get financed, and we recognise that's the tricky bit here, that we're having to maintain additional capacity to respond to the pandemic, and so we can't move resource from reduced hospital wards into community-based locations, because we can't close the hospital wards down, because we still need that infection and prevention control separation. So I wasn't proposing to go into the detail of the individual number of beds and schemes. All I would say is I can assure you that the amount of work and time that's gone in from operational teams, from finance teams, looking at the modelling and working out what we need has been robust. The other thing that we're all committed to do and are working hard on is making sure that we're constantly monitoring the range and volume and outcomes from these schemes to make sure they're both giving a great experience for patients, but we aren't, what I might say, overbuying capacity for a rainy day. And we'll make sure in our contractual arrangements that we build them so we can flex down, as well as if we needed to, if we do have repeat mini waves, which is what Sage and others are predicting we may see through the year, that we're able to respond by flexing up. So I'll open to questions. I'm conscious I'm sure there'll be some, but as I described at the start, the request would be to maintain funding during Q1, which will allow us to both continue to model the likely impact of the pandemic for the rest of the year, but also to finalise some of those future models taking my East Cheshire Trust example as one of them, in terms of what is it we believe is the optimal model for both patients and efficiency as we move out of the pandemic, hopefully during 21-22.
Thank you very much, Neil. We do have some questions. Some people have put comments in, so Dan and Suzanne have put comments in which are probably aligned. So if I could bring Dan in to perhaps voice those two, that was okay, Dan?
Sure. Thanks, Andy. So I guess the question for me really is, obviously we're talking about a significant amount of money being spent, which I think we can all understand the value of that in terms of helping with the throughput through hospitals, etc. I guess my question really is where's that going to come from, and what would have to give in order for that to be funded, or have we got budget for it? Because obviously if it isn't in budget and we're going to have to lose something else, are we confident that the utility of that 1 million or plus is worth more in this project than whatever it's being taken from?
Yeah, and I'm sure Linda will have a view. Obviously, in the absence of national guidance on financial allocations and budgets, it's a really difficult question to answer, because we don't yet know whether there will be any national support to maintain the response to the pandemic. What we do know from our involvement in Cheshire and Merseyside is the approach we're taking is consistent with our peers from across the sub-region, because in the absence of that guidance, the alternative we would be to shut a lot of capacity down. And I think you don't need me to talk through the likely chain of events if we did close all this capacity, which would be real issues accessing hospital services, because they would very quickly be full, and we wouldn't have that flow out of them, and therefore we'd have protracted length of stay in hospital for people who at the moment are seeing timely discharge when they are ready into this additional capacity that we've purchased. The other thing I didn't pick up in the paper, although it's referenced, is this isn't in isolation. Clearly, one of the other areas that we've invested significantly, linked back to Home First, is around home-based capacity, and our local authorities are similarly making the difficult decision that we can't turn off significant parts of the additional domiciliary and rapid response capacity that we've purchased as a Cheshire system in our own homes. Again, this will be playing out in systems across the country as we speak. So sorry, I can't give you a direct answer as to what we would shut down, because it feels like until we get the national planning guidance, we're slightly at a loss as to what it actually means, and is this a pressure or isn't it?
Thank you. Linda, did you want to add anything? Yes. Yeah.
So, I mean, clearly we are, I mean, as in the paper I think does explain in the finance sections that we are effectively going at risk with this because we don't have the budget. We don't have any financial guidance for Q1, and therefore we are going at risk into Q1 for this. I do think we had discussions yesterday, as Neil said, with the hospital, and I think then we are balancing the financial versus the clinical and service risk here. And I think the service risk of not doing this is clearly quite high, and that was really apparent yesterday. I think there is work to do going forward for a sort of more permanent solution in terms of this looks to be a really optimal way of dealing with these patients. So I think there is balance going forward as well, but it clearly is a financial risk, but I don't think that it is a risk that we can avoid given the service and the clinical risk associated with not doing it.
Okay, thank you. Claire, could I bring you in, please?
Thank you. So I think firstly to thank Neil and colleagues. I've been party to a number of conversations, a number of meetings, but nowhere near the number of meetings and the level of detail of the conversations Neil and the teams have been going weeks. I think Linda describes it well in terms of the balance of risk. I think this, it's almost we can't afford not to do this because although we are, as hopefully coming out of the eye of the storm of COVID, there is still a long a long period of recovery around community home-based services to ensure that the flow in our hospitals meets the required standards, so we can get back to some sort of normality. All the people who've been working on this have been challenged in terms of, are these plans reflective of the future rather than the sort of capacity and the sort of maximum requirements when COVID was at its worst? And I think we were all assured, we've had a number of whole system A&E delivery boards where sort of chief execs and others and directors of finance have been involved, and we've put that challenge into the system. So I think, quarter one's going to be a strange quarter. We discussed in terms of finances, we're rolling things forward. Nationally, contracts are being rolled forward. So my recommendation would be that we support this investment, but recognise there is a risk in doing so, and that this is only for quarter one, and there's a whole raft of work we have to do. And the planning guidance comes out, looking at our contract and commissioning intentions, all the things we want to look at in terms of health inequalities, and focusing our investments in early intervention prevention. But we have to do that in the coming months. This is about a decision we need to make today, so that those services don't switch off, because there are still people and patients and our residents who are using these services and are in our collective health and care system that need our support. So I think it's a really detailed, helpful couple of papers. So thank you, Neil and team, and I support it. Thank you, Andrew.
Thank you very much, Claire. Can I bring in Pam, please, and then we're going to Paula afterwards.
Yeah, I've actually made my comments in the comments box, but I actually think this paper's given us an insight into the great innovation that we've made because of COVID. And we've obviously made a lot of changes to services because of it. My comment is, I don't want to lose that learning. And I wonder if we can perhaps have a paper to a future governing body meeting about the changes that we need to keep. Given that I know we can't fund them now, but it would be good to have something which says this was the good stuff, because there's a lot of good stuff has come out, and this is what we need to keep, and this is how we're going to fund it, because we must be able to shift funding eventually, but I think we don't want to lose that because such a lot of good work's been done.
Thank you, Pam. Really good point, and I think we can. I think I saw Claire nodding, so I was taking that.
No. Thanks, Pam. I think you're absolutely right, and I think that's the view of the system. This is about building on the innovation. We all know during COVID, services have been implemented incredibly quickly, and we've looked at innovation. Partnership working has been as good as ever, and we want to, build on that. And I think there is an opportunity when we get the planning guidance and the budgets to sort of, and our providers are open to this in terms of we have to, build on the innovation. Clearly we've got an out-of-hospital cell and a hospital cell across Cheshire and Mersey. They'll both be collapsing into the healthcare partnership in terms of equal importance. So I think we'd be pushing an open door across Cheshire and Mersey. And I think working with our partners locally, that's absolutely the approach we want to take. So thank you.
Thank you. Paula, would you like to come in?
Thanks, Andy. I really wanted to reinforce the point that if we move away from COVID, we're actually looking at papers that describe a model of care that I know we discussed on many occasions through our commissioning intentions works, both in this CCG and in predecessor CCGs. But I think there's something for me about making sure that we focus on, we talk about the AAA, which in terms of making sure that we improve people's experiences of care. And we've heard Neil allude to the fact that there's been positive experience from carers and from patients. Improving health, we know the evidence base for this delivery of a model is substantial, in terms of people's longer term health and well-being. And also as well, this issue about reducing the cost per capita. Now, I know that's a challenge at the moment in terms of understanding our budget, but there is lots of evidence as well that discuss to the value base, both financially and clinically, to this model. So it was less of a question, more to say really that I think if we go with a future approach, we've talked about a paper back to governing body, and we make sure that we amplify those 3 points in terms of the clinical efficacy and the evidence base of this, because it's substantial. as some of the service user and patient experience that we've read about. I actually think it strengthens some of the way we have these discussions at governing.
Lovely. Thank you very much. Suzanne, can I bring you in, please?
Thanks, Chair. 2 points. I support the plan to do the bed-based rehab. I think Dan's just picked up actually on the comments I was thinking of, to what extent are we almost supporting financially the acute sector by paying for these, because where they're having restrictions to protect and to maintain the quality of care within acute and moving more people out, that's becoming a cost out of their block. So in additional funding. So it'd be interesting to see how we manage that. Otherwise, I support it for Q1. And the Appendix A, the number of small scenes we've got, my ask, Neil, would be, what's the strategic approach? So I think Pam and Paula have sort of both touched on it as well, about the innovation, about where we're going, direction of travel, the longer term, and what is required in the community. So something I'd like to see is, what's our direction of travel? Like, I sense there's a move of some things out from acute setting into community, but it's feeling a bit ad hoc at the moment, a bit piecemeal in how it's presented here. So I'd like to see something that's a bit more strategic thinking around, is this a deliberate direction of travel about how we want to work in the future? Post-COVID, using some of the innovation and recognising some of the longer term issues that we're going to have to be dealing with. So that would be my comment, and sort of look for some sort of feedback on that in the future. Thanks.
Thanks, Suzanne.
Yeah, Neil, do you want to respond?
No, it's just thank you, Suzanne. Yeah, and that is noted. And I think the energy, you know, the pandemic's obviously been really tough for people, but when you actually talk to the people on the ground who are involved in some of these new service models, it's given them I guess a real boost and enthusiasm, because some of these things are probably things they've wanted to do for years. And that, you know, using my earlier example, is it appropriate to have an intermediate care unit slap bang in the middle of all the medical wards on a hospital site? Probably not. But there's been no impetus to make it happen, because there's too many things getting in the way in terms of often financial and constraints there. But the pandemic's made it happen, and now I guess everyone's more nervous about, there's a real danger we go backwards as they see it in terms of service models, and we do need to do a concerted piece of work to, as you say, make sure we have the right services in the right place. But that does mean people giving stuff up, as well as just adding more layers on the top. And I detect everyone gets that. It's just obviously easy thing to say and not as easy to do.
Thank you. So I think that's been both picking up Pam and then Suzanne's points on there. There's a very clear ask, which I think Claire responded to, in terms of us being able to articulate what our plan, tactic, strategy is around maintaining those changes to services and the innovation that they have shown. So that's something I think the government body's asking that we do at some point see, as Claire's offered. So that will be useful. Of course, in the new world, we'll very much need to be doing that, working with a number of other partners, because we know that CCGs are highly likely not to have a longevity to them.
Yeah. Can I just pick that point up, Andy, because I think it's quite key in this paper, and you'll note by the names of the people who've been involved in contributing to it, the work we've been doing in the two A&E delivery boards, sorry, we've had two recent A&E delivery boards, both have been led by a new term that came out of COVID called flight controllers, which was a regionally mandated role, which was someone who had a helicopter view of what was going on in the health and care system in relation to discharge processes. And for both Cheshire West and Cheshire East, our respective flight controllers, Alison and Dan, have been coordinating this work with the CCG supporting, rather than the CCG being the people sat there doing all the work and then occasionally going for a chat with the providers. So I think this has been an example of the new world already in action, but the pandemic has helped bring it to the bear, so to speak, because we've needed to work in that really collaborative way.
Lovely. And Claire, do you want to come in?
Yeah, Neil, I think you're being very generous. I wouldn't want to underplay the work that the CCG has done. And I know you're not by saying have a nice chat with the CCG and the providers, but I think there is something about that coordination operational role which the two flight controllers have had across the system, which I think bodes for the future. And Alison Swanson and I can't remember Dan's surname.
Okay.
Thank you. Across the two sort of place systems have been really instrumental and have done a great job. But I don't really want to underplay, as I wouldn't, of course, as the accountable officer, underplay the role the CCG has had and will continue to have.
Absolutely, Claire. That all sounds very positive, and it does give us some hope and optimism for the future. I'll add in my 2 pence worth. I think there's still work to be done in how we view our perspective on this. We still talk about it as hospital discharge, and it be the A&E delivery board that's delivering this. And this is about meeting the needs of the population in a better way. And I think as long as we continue to only look at it from one perspective and saying this is all about making hospitals work better, we will miss opportunities and we fail to fully grasp the possibilities for the future. And I realise that's where we are, but as we move into the new world and new structures, if we can encourage a way of thinking which is around our population has needs and we want to be able to meet those needs in the most effective and efficient way, which I'm sure Chris would support saying can only be done when we understand their perspectives, what their aims are and what they want to deliver, and we engage the front line in redesigning the services, which I know that we're doing. But it is, I think, a shift in perspective sometimes is also needed. But let's not take away, absolutely brilliant work, and it's great to see it, and it does bode well for the future. Back to our paper. So this is the COVID Commission Services Review, and it's page 31 of your pack. Neil, did you want to say anything before I summarise up and ask for agreement on our recommendations?
No, I'm happy that you summarise. I'll step in and correct if I think you misrepresent me.
That's fine. I'll look forward to that challenge. We are asked, it's on page 32 of your pack, we're asked to agree the funding of the bed-based rehabilitation and re-enablement service for Q1, which is a maximum cost of just shy of £1.04 million. And to note the current position relates to the COVID-19 Commission services as they are implemented during 2020/2021, and agree the next steps as approved by the COVID programme board. There has been some debate, particularly around the funding, but I think we are looking to see whether that is acceptable to the governing body or whether it is not acceptable to the governing body. Okay, I see people nodding. Is there anybody that feels that we should be agreeing on that point? No. Okay, thank you. I think we've agreed. Item 1, item 2 is to note, which I'm sure we can do. So thank you. That takes us on to item 5.2, which is the proposal on the establishment of the Joint Committee of the Cheshire and Merseyside Clinical Commissioning Groups. It's on page 54 of your pack, and Claire is going to introduce this for us. So Claire.
Thank you. Thanks, Andrew. So the proposals around a Cheshire and Mersey Joint Commissioning Committee were anticipated the white paper. So we had plans to do this in terms of commissioning at scale for a certain number of services well before the white paper was published, but in anticipation of it. And I think it's just worth noting this is something we did previously when we were the 4 CCGs in Cheshire. We did have a JCC, a Joint Commissioning Committee, where we took decisions on behalf of the population of Cheshire. So I think it's something that as Cheshire CCG we are accustomed to already and understand the value of doing that for certain areas. Obviously we all know the white paper is now out and subject to going through Parliament. That will mean the abolition of CCGs from April 2022. But within the current sort of legislation, CCGs are allowed to form joint committees across different footprints to look at commissioning services together, and that's what this paper really talks about in anticipation. So whilst the default position for the future, and we've all heard Alan Yates talk about the burden of proof, commission at scale only when the burden of proof, and we want to keep most things at scale. There are opportunities and advantages of looking at certain areas of commissioning at that bigger footprint, and that's what the proposal around the Joint Commissioning Committee, the Cheshire and Merseyside CCGs will do. So place takes priority, but there are added advantages of economies of scale of doing things on a bigger footprint. So you can go to Appendix A on which are the terms of reference for that, for the proposed committee. Obviously 3.3, as a member of the joint committee, Cheshire CCG wouldn't be representing Cheshire CCG. We would be making decisions on behalf of the population of Cheshire and Mersey. So whoever represents from Cheshire wouldn't be making decisions on behalf of Cheshire. They'd be making decisions on behalf of Cheshire and Mersey and that total population. We have been working on this as an AO's group, and it has taken an awful lot of time, probably a disproportionate amount of time really. And we've agreed a set of principles, and we've agreed a very high level initial work programme. You can see that in 4.4, so I'm not going to read out the details. These are some proposals, and I think there's still a lot of work to do on the level of services and what we would commission at scale. But I think I've shared with my colleagues across Cheshire and Mersey the work we did for our JCC in terms of what we did at scale, level 1 proposals, and some of those have been adopted. So what I'm looking for really is for governing body to support the development and the establishment of a joint commissioning committee across Cheshire and Merseyside for to start as soon as possible, and it will last through 21-22. I think this is a stepping stone in terms of the future governance of the ICS. So we already have a Cheshire and Mersey group of directors of commissioning. We have a collaborative commissioning forum. This would be a decision-making committee where we look at just those at scale areas. So looking for governing body to support this. I think all the other CCGs have supported it, some fully and some in principle. And I think what we're looking to do is have a first meeting in April to sign off the terms of reference subject to any proposed changes from any of the 9 CCGs, and work through the sort of more formal work programme. So I'll leave it there. Thank you, Andrew.
Thank you very much. So Pam have some questions.
It's not really a question, it's a comment. I know that at the last meeting we actually agreed in principle to the committee, so I don't have a problem with that. What I do have a problem with is the membership. I think there should be it should actually say in there that there should be some sort of lay representation and some GP representation as well.
So Claire, I want to come back. Should we take a few comments and then perhaps Claire, you can respond?
Excuse me. Yes.
Mike, you want to make a point?
Thanks, Chair. Just a quick point in that obviously we're looking at December 2020's draft terms of reference. In the minutes of the meeting, it did say we will be receiving another draft, an updated draft, to come to this meeting. Are we going to see that as a governing body before we have to formally vote?
Okay. Yeah, do you respond there, Claire? And we'll bring in the... Oh, let's bring in Peter. Peter got another point. Sorry, I missed that. Peter.
First of all, I'll echo what Pam was saying about the membership. I think there's some general points really. I think it was the January private meeting, where we endorsed the idea of the committee in principle. And looking across the paperwork, I've got no problems with the concept or the work plan, but it's absolutely around the component. It's absolutely around the components of the membership. What I'm looking for when we delegate either upwards to a committee, a joint committee, or downwards to an ICP, is something which reflects the governance of the CCG. And I'm not seeing I'm not seeing that in this joint committee. And Claire did point out the fact we ran what I thought was a pretty successful joint commissioning committee for Cheshire when we were 4 separate CCGs, and that did mirror the concept of the CCG in terms of inclusiveness. So I was very disappointed, having seen the first draft in January, which did include at least some GP and lay representation, that it's disappeared off the map altogether in this current version. Now, bear in mind that we've not only got to satisfy the lay members' views of what governance should look like, but also the GP representation, which currently sits within this CCG. At the moment, I cannot support the membership proposal that we've got. The committee membership proposal. I simply cannot support it in its current form.
Thank you, Peter. Christine, do you want to voice the comment you put into the chat, and then perhaps bring Dan in to do the same afterwards, and then we'll go to Claire.
Yeah, thank you. Really, just to say, we've heard from Pam about the absence of a lay voice, but the clinical voice isn't clearly articulated in the membership either, so it probably links to Peter's point too.
Thank you. And Dan?
Yeah, I mean, it's just a comment we've spoken about before, but it's actually, when you look at the membership, we're looking at 9 CCGs being within the group, and only 2 of which from Cheshire. So obviously, we've almost we're being penalised for having amalgamated into the single CCG last year, and it's just to be, when you look at the population representations of both, we are underrepresented when it comes to any voting rights, it would seem.
Thank you. And to note, Suzanne has put in her support for the approach in the bar. Claire, do you want to respond to some of those?
Okay, so if I start with the last one first, I have written the other ones down, so that's why I'm going to go with that one first. The nature of a joint committee is that you don't represent your population, you represent the population of the footprint of that joint committee, which is Cheshire and Merseyside. So that they're sort of the governance sort of requirements and rules of a joint committee. So I understand the point you're making, Dan, and I probably may agree to a certain extent, but that's in terms of being a member of a joint committee, it's on behalf of that total population. And I guess if you look at sort of the sub-regional footprints, Cheshire, Warrington, Halton are 1.3 million, 1.2 million of a total population of 2.3 across Cheshire and Merseyside. So we're there, it's about half, maybe a little bit less actually than half, but not a lot more in terms of the population. So, but that's that's the governance rules in terms of that. So I think that just covers that off, if that's okay. So membership, I think, is an interesting one, and one that we debated long and hard as an accountable officers group. I have a lot of sympathy for the views raised, and I'm happy to take those back in terms of, because I think what I'm looking for is support to move forward with this, so that we can sort of start the discussions in a more formal basis from April for the next 12 months. But I do think we need to look at the membership in terms of it reflecting the total governing body responsibilities, but clearly we wouldn't be, if we put this forward as an agreement in principle subject to, it wouldn't be a lay member and a GP from each of the CCGs, because then that would be unworkable. The accountable officers are there. It's proposed that the accountable officers are there to discharge their accountabilities and their commissioning accountabilities on behalf of their organisation on that committee. So I think we just need to recognise that, because as an accountable officer, a GP and a lay member aren't accountable for that direct commissioning decision. So that's I suppose the answer to that. In terms of the terms of reference, very poor English, apologies. I think that they're there because they haven't moved on, because this has been going through various different CCG governing bodies over the last couple of months, just a timing issue. So they will be updated after all the CCGs have made their comments back to each other as part of this process. So subject to our agreement in principle or not today, I will feed back all these comments, and then will be taken to the first meeting of the committee in April, where we can sign those off and then bring them back formally to be ratified by the CCG, because this joint committee will be a subcommittee of Cheshire CCG.
Okay. I haven't got anybody coming back directly, so perhaps I can ask Claire for a little bit as much clarity as you might be able to help us with in terms of what we can, cannot, should or should not be deciding today. So we've been asked to endorse the establishment of the committee, which I don't think there's going to be any problem doing. We've discussed this previously in private, and we've heard today people are in support of that. But people clearly, quite a lot of people, not in support of some of the details, and particularly the membership. But what we've been asked today is to approve a proposal to recommend to membership to change the constitution to allow for the joint committee to be in place. So what are our timelines here? We haven't got a forum for the membership, but we've agreement from membership that they will decide this remotely via email. So when do we need to make that decision? And from the membership point of view, and then for where can we make a decision for the governing body to make a recommendation to the membership, because it feels like that would be a difficult thing to do at the moment, because it would just be an in principle recommendation without the detail.
I'd like us to, if you go to 7.1, I think we can endorse the establishment of the JCC. I think we can approve the proposal to recommend the endorsement to the GPs. So I think we can agree to the establishment of the JCC. I think we agree with the rest of it in principle, and I think that's fine, but we need to do that by the end of the month. And we're looking for the first meeting of the JCC in April, when we'll go through all the feedback from all of the respective 9 CCGs across Cheshire and Merseyside. But I would like us to agree to this. And if we have to agree to it in principle, but I'd like it agreed today so that we can go out to governing to our members and get their support, because we did discuss this at I think both the Senate and the membership meeting, and we outlined the principles of it. And I think that there weren't great antibodies from our membership. They were seeking a recommendation from governing body. So I'm looking that we do that today, Andrew, that we support it, well, I suppose endorse the establishment of it, and we'd have to work through the details in April.
I don't think we'll have any problem endorsing it in principle, but it's what that means, isn't it? I
think, so if I'm honest, sorry to interrupt, I think if that's all the governing body feels able to do, I think that would satisfy the other CCGs, because I think there are mixed views as well from some of the other CCGs. There's been full agreement, and there's been agreement in principle. I think it's important that we don't delay this and that we move forward.
Okay, so can I bring in Wendy and then Peter? You both made comments.
Yes, I think that there is sufficient numbers of us today who actually have got concerns. So I'm happy for Claire to go back and say, yes, in principle, we do endorse it, but there were deep concerns, and we are actually discussing and debating this externally as well with other lay members. So I think that what I'm concerned about is that we don't run very headlong into this and suddenly, well, there you go, it's all a bit too late now. So I'm sure Claire will reflect our concerns strongly to that. But I do understand the need to move ahead as well, Claire.
Thanks, Wendy.
Peter?
Yes, certainly. I've never advocated that we needed a GP rep and a governing body, a lay member from each CCG, but the previous iteration of this had representatives of both on the committee. Now that would be satisfactory for me, because as you rightly say, they're not representing their own CCGs, they're representing the function of governance. And we can all work through those individuals, GPs and independent members, because we keep on forgetting the secondary doctor and the independent registered nurse here, who also should perhaps be represented. You wouldn't be increasing that committee to an abnormal size by at least reflecting the composition of a CCG.
I'm happy to take that back, Peter.
Yeah, but I think until we get to that point, we can't. I mean, you know, we can say yes, we'll take part, but we can't delegate authority to it until we're happy with the governance. So that's what we're withholding. So I suppose in practical terms, if a decision was made, you would have to come back here right now to get it ratified by the governing body.
Yes, which defeats the defeats the objective of the joint committee.
Yes.
Yeah. I think what people are saying, if I get it right, is this is about the creation of a governance structure that would make the decisions as a subcommittee of the governing body, which would be binding. Which is why I've always challenged, and I know, Claire, you disagree, as to why does every single AO need to be on there? Because the governing body is delegating its authority to a committee. And I think what people are saying is that then if that committee needs to reflect good governance and good decision making, which requires a diversity of views and inputs, which I think why people are saying, well, you need some lay non-executive input and you need some clinical input in whatever that is designed. So I think let's take the stage at a time. I think we are in agreement to the principle of the formation of a joint committee. Is anybody in disagreement with that? Is anybody in a disagreement broadly with the terms with the work plan or the rest of the terms of reference, other than the membership of the committee? No. Okay. So then we just need a way forward, don't we? On clearly there's going to be further discussions on agreeing a point where we feel able to recommend to the membership a change of the constitution, and we feel able to delegate authority to this. I think we're going to need to do this prior to our next meeting. It's not going to work because at the timescale that Claire has outlined. So, Claire, is it going to be acceptable that we do that? We say in principle, yes, absolutely, it's going to work. We might need to have a extraordinary meeting or a virtual decision in order to adopt this. It feels like probably, even though this committee has a very small remit, it's probably only going to meet a few times. And so it isn't sort of the be all and end all of delegation of our authority. It is still a significant step in delegating authority. For me, it would probably need to be a short, extraordinary meeting rather than a virtual decision. Claire, how would that fit with the timescales?
Yeah, I can feed back today or tomorrow to my colleagues. So can I just confirm, Andrew, you're looking to have an extraordinary meeting to discuss? I don't think I'll be in a position to bring back before the end of the month on membership, because I think that'd be. I know that a number of the other CCGs are probably in a similar position to us, but we haven't. It's about whether we have the opportunity to discuss that as an AO's group, and then sort of recommend back to respective governing bodies a change in membership.
So I suppose I'm slightly baffled as to then what we're being asked to. We seem to be asked to support something which we're clearly not supporting, but to support something that might come in the future, because we don't know what the proposal that what might come back. So
no. So what I'm saying is, sorry, that I will take back all the comments. I think we are agreeing in principle, which I think is enough for today. What I'm saying is that at the next meeting, so I don't know whether we need to have an extraordinary meeting before we I bring something back to the governing bodies, because that's what I'm saying. I wasn't quite sure what you're proposing around an extraordinary meeting. So we can take the comments from today into the Cheshire and Mersey group, And then I think there are, as I say, I think there are other CCGs who are of a similar view in terms of some of the points raised today. So there will going to have to be another iteration.
Okay, so I think we can leave it as that we are agreeing to, we endorse the formation of the committee in principle. We aren't.
Subject to.
I think that's then for a full stop. We aren't therefore approving a recommendation to the membership to change the constitution or to delegation or authority. Is that
okay.
a reflection of where we are, colleagues? Did anybody feel I've misrepresented that, or we need to be doing something different? No? Okay, thank you. So I think that's what we're agreeing. So we are very much in support of, in principle. We think there's more work needs to be done, so that will need to come back.
Can I just say,
yeah.
Can I just say, Andrew? So thank you for everyone's comments. I think this is going to have to be a journey we're going to go on in the next 12 months, because a Cheshire and Mersey integrated care system and a Cheshire and Mersey, the new body that's in the white paper, NHS ICS body, will be the manifestation, basically the merger of the 9 CCGs, and that body will be accountable for commissioning and the majority of CCG functions across Cheshire and Mersey. So we are going to have to grapple with some of these discussions about, delegating up to a bigger footprint than Cheshire, I think, over the coming months, and that is the direction of travel of the white paper and the ICS. So I think that conversation on the 25th at the governing body development session around the white paper, I think will be useful, so people can really understand what it means and how we want to sort of work over the coming weeks and months. Thank you.
I would agree. I'm speaking for colleagues, but I don't think anybody is disillusioned about that reality. I think it is about a process here, isn't it, of agreement as to what we're agreeing to. Mike, you wanted to come on a quick question.
Thanks, Andy. So when we do see new terms of reference, the one thing that wasn't clear in there is, can the JCC unilaterally, and I say unilaterally because they are represented by all of the CCGs, but unilaterally change the work plan, or will the work plan proposals have to come back to all of the CCGs if there are any changes?
No, I think once we agree terms of reference for the JCC and the membership, it will make the decisions on the work plan. I mean, we'll report back to the governing body, but I think this is the point about, if we're going to have a JCC, it would defeat the object to have to keep coming back, and your representatives on that committee would then feed back into and report to the respective CCG governing bodies.
Okay, I thought we probably finished that item, but clearly we probably haven't, because that's not how I read the terms of reference as they stand. It says that changes to the work plan need to be agreed by the CCGs.
Okay.
And that would be essentially
okay, apologies, but if it's in the paper, sorry. Okay.
And that's how I read the paper. It says, Matthew, what's your view on that?
Yeah, so as it stands, the terms of reference is saying, any sort of substantial changes would need to come back to either governing body or membership, depending on the CCG. If, however, future iteration comes by and you are seeking that delegated authority to make changes, that could happen, but you would need to agree that. But I would imagine people would question the scope of that. We're taking on board all Claire's comments around the direction of travel and what we need to achieve. So I think as it stands now, it's saying it needs to come back as a recommendation from the joint committee to each respective governing body. But to shorten that, you would just agree to delegate that decision-making authority to the committee or an individual.
Okay, that's my mistake. Apologies. If it's in the paper, I guess it'll be that.
Okay, thank you. Sorry, that was slightly difficult, but I think we have got somewhere which we can take forward and hopefully won't delay what I think we do wish to happen, which we do wish there to be a joint committee which is formed, but we just want to get that right. So I hope that is the message. Thank you very much. That On then to item 5.3, which is on page 74 of your pack, and is financial planning update. Linda.
So hello everyone. So this is just the financial position for the end of January with forecast outturn for the full year. If you look at the paper, I mean, we're now getting very much towards the year end, and so things stop changing an awful lot. So the paper is very similar to the one for the end of December position. The financial position at the end of January 2021 was a forecast outturn deficit of 4.6 million. That's a slight improvement on the previous month. I would like to confirm that since the report was written, the CCG position has improved again. We're now reporting for the end of February a break-even position, and we may even deliver a small surplus at the year end. The improvement has been delivered in the main due to additional allocations being received late in the year, and mainly from the healthcare partnership. As in previous months, we predict that the CCG will meet the mental health investment standard and will meet its running cost targets. We have achieved 3 out of the 4 of the Better Payment Practice Code, so we continue to look at that and continue to try and pay our invoices as quickly as possible. And we're having a big push for the year end on that. Arrangements for Q1, I have put in some additional information around the financial arrangements for Q1 from a national NHS webinar that was held, but as we've already reported, we are still awaiting any real detailed information on Q1, and we're anticipating that we're going to get some guidance on the 26th of March after we have received, after the NHS board I think is on the 25th or the 26th as well. So we're going to get more information then. So that's sort of an update. Does anyone have any questions? Ooh.
Any questions?
No?
Just
Claire?
Yeah, so thank you, Linda. So clearly great news in terms of potential year-end position, so sort of financial coming and goings. But I think the actual report is really clear. So I just wanted to so that's it's really well written and well presented. So I think it makes it a lot easier for us all to sort of understand the sort of comings and goings. So thank you.
Thank you, Claire. Thank you very much. I'll pass that on to my colleagues as well, who do all of the detail. There's loads of detail behind this. Suzanne and Peter and Gwydion get sight of it. So.
Any further questions or comments on that financial planning? No? Thank you very much. We are simply asked to note the financial position as of 31st of January 2020 and note the financial risks faced the CCG, and then to further note the information received in respect to the financial framework for Q1 of 21-22. I will look towards what I hope to see as nodding heads. I see some nodding heads. I think we are in agreement and we have noted that. Thank you very much. That moves us to 5.4, which is the Government Body Assurance Framework, and it's a presentation and refresh. That's on page 79 of your pack. Matthew.
Thank you, Andrew. So, conscious of time and conscious of the size of the paper, I'm not going to go through each page in line, but I'll try and get to the main recommendations and where you need to look at if you need to revisit the recommendation. First, I just really wanted to thank a number of people who've helped really to pull this together, including people like Phil Meakin and all the risk leads who have spent a lot of time pulling together the refreshed risk. I'd also like to thank all of you, because in one way or another you've been involved either through workshops or through governing body meetings or reviewing the risks as well, and I appreciate a lot of time's gone into this. I'd also, hopefully from reading it, you can see where all your feedback and your comments have now been reflected either in the report or the refresh governing body assurance framework, and hopefully you can see your DNA sort of run through all of it going forward. I'm going to focus, if that's okay, Andrew, with the various recommendations and asks for approval on the report, if that's okay. So I'll go to the first one really, which is on page 82 of the pack, where I've highlighted that through the process of revising and agreeing the strategic risks, there were some suggested amendments to our approved strategic objectives we signed off in September. And I've highlighted what those proposed amendments are in Appendix A, which is page 89. So the first ask really of the governing body is whether they are happy with the proposed amendments following your feedback to the wording of the strategic objectives. And then if you are, we'll take the necessary steps to reflect that in terms of all the CCG branding. So Andrew?
Yeah, it's fine.
No, everyone agrees on that one? I'll just take a nod if that's okay. Yeah. That's fine. I'd rather do it.
Sorry, Matthew, are you asking us to agree that now, or we're going to go through the paper?
Well, rather than ask, I'm happy either way, but there's about 8 or 9 recommendations, and it's whether you want to try and go through each one. I'll whiz through them all if you wish, and then we can summarise it at the end, Claire, if you want, and that's fine. So again, as part of the workshops and part of what we're doing, one of the things that we also agreed and drafted was a risk appetite statement for the CCG. It's not something we've really had before. That's also highlighted on page 82. And whilst it was circulated in January virtually, and a few people did get back to me saying they approve it, I don't want it formally approved today. That's our risk appetite statement, and that will be presented in the governing body assurance framework. What I've also highlighted in the paper, and this is around page 83 and 84, is the proposed sort of process going forward around the oversight and management of the risk around the assurance framework. Figure 1 gives you that kind of diagrammatic oversight of how we do that, and the role of our committees of the governing body in having oversight and a greater involvement in shaping those risks before it comes back to the governing body. You'll also see in there a proposal that the governing body itself receives a consolidated governing body assurance framework quarterly, and I've highlighted dates when that would come into effect if you approve that. So that'll be one of the asks for approval on there as well. On to the next sort of recommendation, sort of a minor one. You will note that the format of the assurance framework, which is in Appendix B, has changed, and that's taken on recommendations from best practice and from support from internal audit based on what's worked well elsewhere, but also from our workshop. And you'll notice that we've strengthened the links between our strategic risk and our strategic objectives, our commissioning intentions. Probably for the first time, you've seen a target or an acceptable risk level for that, which again is seen as good practice, and equally for each of our risks, a separate risk appetite of what we're prepared to accept. On to the final couple. So the last time you saw the consolidated governing body assurance framework was in September, and those risks were still live. And as we refreshed the risks, the ask is, and you'll see this in table 3 on page 86, whether to migrate what is the current or old, depending on your terminology, risks into the new refreshed governing body assurance framework for 21-22. So there's a couple of asks in there around agreeing the migration of 6 existing ones into the new one. There's an ask around approving the recommendation to take out the what was governing body assurance framework risk around learning disability transforming care, and because of the reduction in the risk score, put that onto the operational risk register, and also approve the retention of a standalone risk around the COVID-19 pandemic, which reflects where we are today. And then the last ask of governing body really is what's in Appendix B, and what is also highlighted on page 91 as a summary is the new risks for the period of 21 to 22 for the governing body, and the initial risk scores, and as they are. Page 91 shows you the heat map and the summary of all these risks, where between 92 and 130 gets into the greater detail. Just want to highlight that this is what I'd be asking you to sign off today, but as outlined in the paper, the expectation is that the committees do take these away, keep oversight on them. So do fully expect that you'll have the ability to change and tweak and then make recommendations back to the governing body when it comes back in June. But hopefully you see from the paper a greater rigour in terms of the oversight of those strategic risks held by the committee and the chairs and the risk leads. And I'll leave it at that, because that was a bit of a whistle-stop tour on that one, Andrew. So happily take any questions.
Okay, thank you. I think Suzanne, you have a comment?
Yeah, thanks, Chair. I thought it was a really good exercise. I think you guys need credit, Matthew and Phil and the team, for the work you've done. I think it's a massive improvement on where we've been. I just had a particular comment on the risk appetite. I wasn't sure about the first paragraph, why we actually needed that. It felt like a bit of political jargon to me about our direction of travel, blah, blah, blah. And it doesn't really talk about risk appetite at all. Whereas the second paragraph is far more powerful as a message on its own without the previous paragraph. That would just be my comment and observation on that. And in terms of the finance and the strategic stuff, we did have a very quick look at it at Finance Committee last week. But we didn't have time to really go through it in detail, and I have to say I think there's a bit of work that needs to be done on that still. It's a little bit too operational feeling and needs to be lifted up again to a more strategic level. But otherwise, I think it's some great stuff. And finally, just on the sustainability one, something I've banged on about before, I would like to see a baseline being done so we can measure reductions. And I must admit it was quite late when I was looking at it, but I couldn't see anything in there about doing the baselines. I'm just looking for some assurance that actually we are doing that, in case I've missed it. Thank you.
Okay, thank you. So I'm quite happy with the risk appetite suggestion. I agree. I think the second paragraph is the powerful one, and not the first time I've been accused of doing political jargon, so I'll take that compliment, I suppose. In terms of the, I suppose, recognition, absolutely. Sorry, I probably should have mentioned this. There was some issues in terms of technical committees, sometimes because we've actually, closed down the committees due to reducing the burden and they're starting back up again. So the opportunity for committees to fully review all these has been limited, but we did try to engage with members and chairs to get to a point, but fully recognise that you probably really want to get your teeth into them and make some changes. But again, for today and going forward, if we're prepared to agree that initial sort of baseline of what we think the score is, I think we all recognise it might change or it might not, but all the stuff that goes in the assurance framework will probably be refined over the coming weeks and months. In terms of the environmental one, I'll probably seek support from Tracy on that one, if that's okay, in terms of the baseline.
Yeah, the words carbon neutral plan for Cheshire with reporting system to show plan compared to actual trajectory of achievement, that should refer to having a baseline carbon footprint, and that's part of it that needs to happen. So I'm sure Gwyd may want to chip in, but I think we can amend the words to be more clear that we need to know our baseline, then our plan, and are we on track, and that's what that implies. But let's tighten that up, Suzanne.
Thank you very much. Could I bring in Peter, please, and then Leslie afterwards?
Thank you, Dr. Wilson. Really great piece of work, and I think this is going to be a very useful assurance tool for the future. It was, I think as well, pushing the work down, the detailed work down to the committees is going to be really helpful, because we don't have time at governing body to put these GBAF risks under the microscope, and we've got a bit more time at committees. What I would, in terms of the recommendations, I think on the covering paper, it's the role of the oversight committees to monitor their assigned GBAF risks. I think it's a little bit more than that. I think you've hinted at that already, because I think it's monitor and basically maintain the mitigations and actions, which is the responsibility of the committees from then on. And I'd like very much, and I'll certainly do this in any committees I sit on, is to look at them all as closely as possible to see whether we've really got things in there. And this goes back a bit to, I think this goes back to the climate change conversation one as well, that we can actually check progress on through the year. So, you know, are they smart, if you like? Are they smart enough to be able to actually monitor against? And I'm hoping the committees will actually do that. And you know, and finally, you know, I couldn't help thinking. I didn't raise it at the time, but I couldn't help thinking when people were discussing about the vaccination effort earlier on in the meeting, and talking about equity for our population. And I thought to myself, then we are walking the walk here, because that's, you know, it's an objective of the governing body, a strategic objective to pursue equity, and here we are actually doing it. And I was very pleased to see there is a GBAF item which actually incorporates that, and it seemed to me that we're already pursuing some of those things really, really well. It's great to see. So great work, Matthew and team. So that's the end of my comments.
Thank you, Peter.
Thank you very much, Peter. Can we bring in Leslie, please? And then I think, Neil, you have something to raise. So Leslie, please.
So my first question was answered, and yeah, again, echo the thoughts of everybody that this is a good improvement, and I'm really happy with the wording and content, and there's a lot of work been done. So my question may be a bit naive, but I don't know whether the register would change over the coming year, given the changes to the fact that the CCG will be finishing next April, and how that will look going forwards. And it may be something that you can't answer, but I was just curious to know whether that would impact on it at all.
So Andrew, I can give my view on this one if you wish. So I think I talked about this earlier before around whether as a CCG we exist or not post-April, functions and risks are still around. So there is something about, you know, the migration of probably all CCG risks across the patch need to be picked up by someone, and that could be the ICS, and that could be other areas like the ICPs as well. In year, things can change. It's whether a strategic risk will considerably change for it not to stay on a governing body assurance framework, but the mitigations do change. Equally, there's always the flexibility for new risks to come onto a governing body assurance framework if it's either escalated by a committee or externally by regulators as well. So the assurance framework could change, and it might need to change as greater clarity is received around what happens from April on next year. But hopefully we've got to a point where we agree that these are what we feel are our main strategic risks as an organisation. So change will probably only be in terms of scores and the mitigations and the controls, and it might not be that we remove them entirely within the next year. But that leads to your question, really, you know, where would they go from April onwards? And that's all part of the work that we've all got to look at as part of this future.
Thank you. Neil, you've got a comment.
Yeah, so mine's a slightly dry technical point, so it may appear a little pedantic, but the strategic objectives which we're proposing to sign off a number of changes, I know I'd championed changing strategic objective 7, which describes NHS constitutional standards, which is a very small subset of all the national standards. So I'd asked that the word constitutional wasn't in there, because that would be very limited against our broader set of objectives. So my simple suggestion is to take the title of Risk 2108 as the strategic objective as well as the risk, because that's much broader and just describes national and local performance objectives we set our providers. So sorry, I appreciate it appear slightly dry, but it feels very narrow. If you think what's in the NHS constitution, it's a very limited number of indicators.
Don't think so at all, Neil. I think that's quite a substantial change. I don't see anybody looking upset or perturbed by that proposal.
Neil, what was the wording again, just so we can
I just take the title out of 2108. It's the title of the risk, which I think when I'd originally proposed that, it was for strategic objective 7. So I would just use exactly the same wording in the title.
And what's that wording, Neil, so that we all can...
Sorry, I'll just have to flip back over onto my PDF. Sorry, I'm scrolling.
Page 115.
Thank you, Tracy. It is the inability of providers and partners to effectively deliver the standard of performance we have agreed with them based on national and local priorities.
A snappy strategic risk. Okay, is anybody in disagreement with changing that?
Neil, are you saying that should be the objective, or are you saying the objective?
Obviously, it needs slightly rephrasing to change it from being an inability, but you know, the second part of that sentence, if you like, I can email the exact wording, but the premise is that it's broader than just the NHS constitution. So it would be that the ability of providers and partners will deliver. So it's just a wording change, but the substance is what it says in that.
So Neil, if you can circulate that wording amongst the governing body post the meeting, and we can maybe just agree that risk, that objective change, that would be useful. Everyone's in agreement with that, Andrew.
Yeah, I
more
can see.
Snappy, please. So,
okay. Yeah, I'll keep it as short as I can.
Lovely. Right, thank you. I think people who have the opportunity who wish to comment have had the opportunity to comment. So I'll pause in case that's not the case. Nobody's waving at me frantically. So if we can go to those 7 recommendations. Matthew's already read them out. I'm not going to propose that I read them out again. Are there any recommendations that anybody feels we can't agree? Okay, thank you very much. And so just to reiterate, a number of comments in the box about the quality of the work, Matthew, and I think it's been said by a number of members. But thank you for you and your team for that work. It is a good-looking GABAF now, so thank you very much for that. And we have agreed those recommendations, which takes us to point 6.1, page 131 of your pack. This is the Governing Body Forward Planner. It is for noting. The planner you have in front of you are things that have been suggested to be on the planner previously. There may be additions. I know that there have been discussions around the wish to see some things come back around the reset and recovery work, and I've been discussing with Claire about that, which we're planning to come for April in addition to what's on the planner. But that's just in outline at the moment. Is there anything else anybody feels needs to be on, off, or any comments on the forward planner? Okay, so Pam, do you want to make your point?
Just that we talked before about not losing all the good work that we did as a result of the changes, and so we need to put something in there, but maybe it comes in with the strategies and plans, or I don't know, but I don't want to lose that.
Absolutely. So yes, we can put that on in some way. We can look at that. And Tracy, comments about the patient story?
I just wondered if it was worth us forward planning patient stories to link in with the agenda items and to make sure that we have time for them as well. I think it's really important that we continue to do that.
I would agree. I think that's been slightly inhibited by COVID-19 and pressures and both the difficulties of getting some of those stories under the present regulations. But yes, I would absolutely agree. Suzanne, we've got something to mention.
Sorry, yeah, I haven't got it in front of me now, but just to say, the discussion earlier on about mental health and asking for a paper to come back, maybe it was April or May, actually, I think.
It wasn't April.
Sorry, was it May? Okay. There was an
well, definitely wasn't April anyway.
Okay, for May then.
Okay.
Andrew, could I just ask, I just want to, and maybe this is a sort of a conversation offline, we've obviously got the government's roadmap for unlocking and sort of moving back to whatever normality looks like, and just sort of the governing body's appetite about face-to-face meetings and when and how we manage that. So I think it's, personally, I think it'd be really important that we start having face-to-face meetings as quickly as possible, but obviously within the sort of the rules and the sort of as safely as possible. So I think we just need to think about that when we're building in the agendas, and just sort of think. So I'm guessing we're probably not looking till face-to-face until possibly July, but I think it would be good if we could begin to plan for that, and for the subsequent months.
Yeah, no, I would agree. We do need to meet as soon as we're able to safely meet, particularly given that some governing body members have not met each other face to face yet, despite the fact that we've been informed for some time. I think there's also a consideration of whether we actually have hybrid meetings and not just necessarily obligatory face-to-face meetings, particularly thinking about climate change commitments that we've made and the size of the area that we serve. But, so perhaps we can discuss how we might do some of those things, sort of as a hybrid between face-to-face and virtually.
Okay, we can discuss that. I think governing body should be face-to-face. The other committee meetings potentially hybrid, but I do think it's important personally. But I'll leave that.
Thank you very much. That brings us to the end of our formal business. If there's any other business to be raised, nobody has raised anything with me in advance, so my assumption is that there will not be. Paused, nobody's objecting. Thank you very much. Thank you very much for everybody's contributions today. My apologies, we are finishing a little late, but we're not as late as we have been on some occasions. So thank you for everybody's contributions, and thank you for the members of the public that have been listening to us, and we look forward to seeing you again next month. Thank you.